Hello, we are here with Dr. Nicolás Quesada from the Pontificia Universidad Católica in Santiago de Chile, who will be presenting us his paper about bariatric surgery in cirrhotic patients, a match case control study on December the 10th for our journal club. Hi, Nicolás.
Hi, Sebastian. How are you? Very nice to meet you.
Me too. Fine, thank you. So let's talk a little bit about our visual abstract and some questions to introduce to the audience about your paper. So I will give you a few questions that may introduce to the topic, and then if you can answer them for or the audience to see a little bit about your study. So let's see. Number one. Operative time was not significant different between both groups, but do you experience any technical difficulties in the cirrhotic patients group?
Great. Yeah. I mean, this is a very selected group of cirrhotic patients because they were all child-up patients. Then all of them had no portal hypertension. I guess that when you have portal hypertension, that could be a real problem in the operative room. Then I guess that the principal problem or the main problem with the patients is that the liver is not larger than the regular one, but is harder, right, or heavier. Then we use like a steel stick to lift up the liver to expose the hiatus, and in that moment when you're placing that stick, you can feel that the liver is different, and you have to take care of not damaging the liver when you're lifting it up. Okay, then I would say that probably that was our main concern of not making injuries to the liver when pulling it up. And if you have portal hypertension, probably that would be a very hard problem to deal with. But in this case, it was not a problem at all. As you can see, we did 69% of Roux-en-Y gastric bypass patients, and we had no problems with fundal varices or gastroesophageal junction varices. So there was no problems about that.
Great, thank you, Nico. Next question. Traditionally, Roux-en-Y gastric bypass is not recommended in cirrhotic patients, but your data shows it's a safe procedure in child A patients. What's your opinion about these findings?
Yeah, as you can see in the paper, and I invite everyone to see the paper, we did a very extensive review of the papers about it. And what we realized is that most of the bad results about Roux-en-Y in cirrhotic patients come from open surgeries. Okay, when you do a laparoscopic surgery and when you work in a center with a huge experience in laparoscopic bariatric surgery, as the sector we are, I can say that very humbly, probably you will not have such of bad outcomes reported before. So this is true for bariatric surgery, this is true for cholecystectomy, this is true for hernia surgery. As soon as you can do it by laparoscopy, probably in child-up patients, you will get good results as it is for no cirrhotic patients, and this is what we are showing in our results.
Great, excellent. And following this question, as you said, compared with previous articles or previous literature about doing Roux-en-Y gastric bypass in this kind of patients, what do you think are the key points to having results as yours?
Well, I guess that this is a very special population of patients, right? They obviously have a high risk of complications, and not only surgical complications. They have high risk of hepatic decompensations. And then if you are trying to do this kind of surgery, you have to have a very good team supporting you, behind you, right? And with that, I mean, you have to have a good team of pathologists, good transplant surgeons behind you. And you have to have a very good intensive care unit to deal with complications. And as you can see in our paper, most of our severe complications were not surgical complications, lucky for us, right? Were kidney complications, atrial fibrillations, and medical problems that can happen to these patients. You have to realize that these patients are frequently older than the regular bariatric population, and they have more comorbidities than the regular bariatric population. Then these medical complications can occur, and you have to have a very good team supporting you after the surgery. And of course, the pre-op optimization is also very important, and then the nutritionist, psychologist, hepatology, the diabetes doctor, they are very, very important to get a good result, and the patient should be optimized previous to the bariatric surgery.
Great, excellent. So, Nico, thank you very much for your time. I will see you in the Journal Club the next December the 10th. We invite you all to register to this Journal Club at our website at IFSO. And this is a great topic. It's a great paper. And one more time, Nico, thank you for your time. Thank you for the hard work you put on this paper. And we hope to see you, everybody, in December the 10th.
Oh, thank you very much, Sebastian. It's a great pleasure for me to share this information with you. Thank you so much.
Thank you.
Goodbye. Bye-bye.